Okay, now we'll continue with gastrointestinal disorders and let's continue with starvation. Starvation is basically a form of undernutrition that could result from inadequate ingestion of nutrients, malabsorption. It could be because there's an impairment of metabolism or even loss of nutrients due to diarrhea or increased nutritional requirements, for example, when that happens in cancer or under infection. In essence, when the patient is without any sources of food for days, there is a compensatory mechanism. If you remember when we discussed the aerobic and anaerobic metabolism during the Krebs cycle, basically what happens is that remember when you eat, your intake is based on carbohydrates, proteins, and lipids. The first source of glucose is used for the cellular metabolism. The rest is stored in the liver in a form of glycogen. When there is a starvation process, that glycogen is broken down by the process of glycogenolysis after 6 hours if there is no food intake. In addition, there is new sources of glucose formation when the patient goes after 8 hours without eating, and that basically comes from protein sources and from lipids as well through the process of gluconeogenesis and because of catabolism. And basically, if you recall, when this process is exhausted, there is at the end shift to the anaerobic metabolism, producing not only lactic acid but also ammonia and ketone bodies. So now let's discuss even though it's rare in this country, what is protein energy undernutrition that used to be called in the past protein energy malnutrition. And I want you to emphasize, for example, that even though marasmus is a protein energy malnutrition or undernutrition, is basically a deficit of all macronutrients. So here in marasmus, there is a deficiency in carbohydrates, deficiency in proteins, and also deficiency in lipids. So every single micronutrient is in deficit. The severity of marasmo as well as kwashiorkor it ranges from subclinical deficiencies to obvious wasting with edema, hair loss, and skin atrophy up to starvation. Now, the main difference is, for example, marasmus again is also called the dry form of protein energy undernutrition. These patients have weight loss and depletion of fat and muscle. In developing countries, marasmus is the most common form of protein energy undernutrition in children. These patients are emaciated, they have no adipose tissue. In contrary to kwashiorkor, which is also called the wet or swollen or edematous form of protein undernutrition, is a risk after premature abandonment of breastfeeding, which typically occurs when younger siblings are born, displacing the older child from the breast. So children with kwashiorkor tend to be older than those with marasmus. Kwashiorkor may also result from acute illness, for example, gastroenteritis or another infection, probably secondary to cytokine release. In a child who already has protein under nutrition, a diet that is more deficient in protein than energy may be more likely to cause kwashiorkor than marasmus. So the main difference here is that marasmus has all energy malnutrition, carbohydrates, proteins, and lipids, and that's the reason why they go into more catabolic state versus kwashiorkor that mainly what they lack is protein. Even though they could lack carbohydrates, these patients mainly lack protein, and that's the reason why you know that when proteins are deficient, there is hypoalbuminemia. That means decrease oncotic pressure. That means edema, and that's the reason why these patients basically are edematous, and they have a distant abdomen, they have hepatomegaly, they have peripheral edema. So in both marasmus and Kwashiorkor, the cell-mediated immunity is impaired, increasing susceptibility to infections. They basically die from pneumonia, gastroenteritis, and even up to sepsis. This is a picture of marasmus. You can see the patient here, cachectic, versus Kwashiorkor, where the patient is all edematous. The initial metabolic response is decreased metabolic rate. So to supply energy, the body first breaks down adipose tissue. However, later when these tissues are depleted, the body may use protein for energy, resulting in a negative nitrogen balance. Visceral organs and muscles are broken down, and there's decreasing weight. There's loss of organ weight in greatest the liver and the intestine. So also the heart and the kidney could be affected. We already discussed the symptoms, and basically the treatment for this is oral feeding, but has to be very slow. Supportive care. So worthwhile, the most important preventive strategy is to reduce poverty. For mild or moderate protein undernutrition, including brief periods of starvation, can be treated by providing a balanced diet, prefer orally. Liquid oral food supplements, but of course lactose free because of all the gastroenteritis problems that the patients tend to have, because diarrhea could complicate the course disease. In severe protein undernutrition or prolonged periods of starvation, these patients require hospitalization. The first priority is to correct fluid and electrolyte imbalances and put the patient on antibiotic prophylaxis. And the next priority is to supply micronutrients, preferable with parenteral nutrition, then slowly introduced feeding either by oral or nasogastric tube. So long term, how the body compensates is how I explained already. Ketones are produced by the breakdown of pyruvates and lipids. Fatty acids as well produce ketones, and as well as ammonia. But the last resource is basically to break down muscles and visceral proteins, and that's the reason why these patients go into cachexia. So now let's briefly discuss the functions of the liver before we go into hepatitis. So this is basically statistics that you could read on your own, and anatomy. Basically, the liver has four lobes, and major division is right and left. 25% of the cardiac output is shunted to the liver. Remember that liver participates in the portal vein circulation, so that's the reason why when patients have cirrhosis of the liver or any acute or chronic liver disorder, this portal vein could be occluded, and patients could develop portal hypertension and esophageal varices. Remember that the liver has an endocrine and an exocrine function, releasing insulin, glucagon, somatostatin, and pancreatic polypeptide for breakdown of proteins. Liver, remember that it could regenerate itself, and participates also in the mediated immunity by reticuloendothelial cells and Kupler cells that are specialized in macrophages for phagocytosis and the adaptive immune system. So the main functions of the liver are glucose production through the process of gluconeogenesis or glucogenolysis, synthesis of cholesterol and fatty acids, protein synthesis as well. So here you're going to see if the patient has liver problems. Glucose could be affected. Patients could either have hypoglycemia or hyperglycemia. They could have hypercholesterolemia. They could have decreased albumin because one of the functions is protein synthesis. In addition, they could have coagulopathic disorders because the liver is in charge of clotting factors, angiotensin as well, and growth factor. In addition, is in charge of oxidative deamination and transamination. So that's the reason why not only LFTs are elevated, but transaminase as well. Carbohydrate metabolism by the synthesis of glycogen. So here you're going to see how the glucose could be affected by either hypo and hyperglycemia. He's also in charge of drug and poisoning detoxification. So that's the reason why patients go into a hepatic encephalopathy by accumulation of ammonia. And in addition, because of protein synthesis cannot take place and ammonia accumulates. Is in charge of, besides the stomach, of the absorption of alcohol, helps with bile production, so patients would go into jaundice due to cholestasis. In addition, clearance of bacteria by portal circulation. When this is obstructed, patients can have a lot of translocation of bacterial and sepsis. This is the portal circulation as I explained earlier. If you come here, realize that the portal vein gets branches not only from hepatic veins but also from gastric veins, esophageal veins, mesenteric, superior and inferior, as well as from superior vena cava and inferior vena cava. So when I explained about esophageal viruses, remember that the upper two-thirds get supplied from the superior vena cava as well as from the esophageal veins. Those are not the circulation system that participates in esophageal viruses formation. The problem is that when the pressure gradient increases, more than 10 to 15, depending on the book that you're reading, there's a shift of pressure from the inferior vena cava and portal vein into the lower pressure systems, which one of those are the two-thirds lower of the esophagus, producing new shunting or new collateral circulation, which are called esophageal viruses, that when the pressure increases at this level, then is when the esophageal viruses burst and bleeding or hematemesis occur. So now let's talk about the pathophysiology of hepatitis. Briefly, acute viral hepatitis is a diffuse liver inflammation caused by specific hepatotrophic viruses. A non-specific viral prodrome is followed by anorexia, nausea, and often fever, right upper quadrant pain. Patients develop jaundice. Most cases resolve spontaneously, but some progress to chronic hepatitis. So basically, it's an inflammatory process produced by a virus. There's also another form that is called acute fulminant hepatitis, that this could occur in patients that have hepatitis B or C, resulting in hepatic necrosis and even hepatocellular carcinoma. Remember that this inflammatory process will activate the inflammatory cascade and releasing cytotoxic T cells and natural killer cells. So as I mentioned, there's a normal prodrome of 2 weeks after exposure. Patients would have non-specific symptoms. They include profound anorexia, malaise, nausea, and vomiting. Sometimes patients that smoke, they develop a new distaste for cigarettes, and often fever, right upper quadrant pain, urticaria, and even arthralgias. Then it goes to, after 3 to 10 days, an icteric phase. which the urine darkens, followed by jaundice. Systemic symptoms often regress, and the patient feels better despite worsening jaundice and worsening liver function tests. There's mild hepatomegaly and also splenomegaly due to hepatic destruction and bile stasis that produces ictures. Then, after 2 to 4 weeks, jaundice fades, and this is called the recovery phase. Appetite usually returns after the first week of symptoms. Acute viral hepatitis usually resolves spontaneously 4 to 8 weeks after symptoms onset. Types of hepatitis, there's hepatitis A, if you recall, this oral fecal transmission primarily. Also has an incubation period of 4 to 6 weeks. In the incubation periods, basically there is no symptoms whatsoever. Remember that IgM is the first immunoglobulin that is released and signifies the current infection, versus IgG means either comfort immunity for vaccination, or because there is past infection. Then hepatitis B, mainly produced by blood and body fluid transmission, and also sexual transmitted disease. Also is seen in patients with dialysis, homosexual men, IV drug abused, healthcare workers that are not vaccinated. The major contributor to chronic hepatitis, cirrhosis of the liver, and even hepatocellular carcinoma. Incubation period is also 6 to 8 weeks, and there is a vaccination available for it. Hepatitis C, and also called non A, non B, is also blood-borne, usually through transfusion or IV drug abuse. There is co-infection with HIV and hepatitis B virus as well. Also leads to chronic liver disease. There's no vaccination available. In addition, there's hepatitis D, E, and G. D is the only in persons with hepatitis B. Hepatitis E also has the same way of transmission as hepatitis A, which is oral fecal. There's no vaccination available. Hepatitis G, there is parental or STD, and also may slow HIV replication and increase the CD4 count. Now, before we go into cirrhosis of the liver, diagnosis of hepatitis is basically mediated by liver function test. The AST and ALT transaminase are elevated. Initial diagnosis must be differentiated from other causes of elevation of liver function test. Patients should have not only LFTs and transaminase, but bilirubin and alkaline phosphatase. Acute hepatitis patients tend to have hyperbilirubinemia. Alkaline phosphatase is elevated. If you do an ultrasound, most likely there is presence of cholestasis. Liver biopsy is usually not needed unless the diagnosis is uncertain. You could do also serologies, IgM, with the antibodies for HIV-A. In addition, you could do hepatitis B surface antigen. So the main thing here is to remember that IgM antibody is present in recent acute infections, and IgG is basically present in recovery or chronic. Now, in your specialty classes, you're going to see that, for example, in patients that have hepatitis C, there is no such things as IgM or IgG. Basically, is protein chain reaction to be able to differentiate antibodies against hepatitis C virus when the patient is recently exposed, or when the patient had a chronic or recovery phase. In addition, you will see in hepatitis B in your specialty classes that there is a hepatitis B E, little e antigen, and antibody that basically determine how the viral load is present, or the how severe is the infection. That is confirmed serologically by measuring hepatitis B E, little e antigen, and hepatitis B little e antibody. Also determines prognosis and also guides for antiviral therapy. Treatment basically for hepatitis B is supportive. There's no treatment that attenuates acute viral hepatitis. Alcohol, of course, should be avoided, and for cholestasis, you could give cholestyramine and basically a rest. Now let's discuss a little bit about cirrhosis of the liver. Cirrhosis is basically a late stage of hepatic fibrosis, and that's the key word, that has resulted in widespread distortion of normal hepatic architecture. Cirrhosis is basically characterized by nodules surrounding dense fibrotic tissue. Symptoms may not develop for years, and patients sometimes have anorexia, fatigue, weight loss, and the late manifestations are due to portal hypertension, which patients develop ascites and even liver failure. So, the pathophysiology of liver cirrhosis in response to injury or any inflammatory disease in the liver, growth regulators induced hepatocellular hyperplasia, and also arterial growth angiogenesis, meaning formation of collateral circulation and new vessels. Among the growth regulators are cytokines and hepatic growth factor. There is new vessels produced within the fibrotic tissue that surrounds nodules. These vessels connect the hepatic artery and portal vein, restoring the intrahepatic circulatory pathway. Such interconnected vessel produce low volume and high pressure venous drainage. As a result, portal vein pressure increases. There is distortion in blood flow, contributing to portal hypertension, which basically increases because these nodules compress the hepatic venules. So the main complications of cirrhosis of the liver, which is an irreversible inflammatory disease with fibrosis, and the parenchyma is nodular and distorted, is portal hypertension, which is the most common serious complication of cirrhosis, followed by GI bleeding due to esophageogastric or rectal variceles, ascites, acute kidney injury with hepatorenal syndrome, and pulmonary hypertension due to portopulmonary hypertension as well, and major vasodilation and right to left shunting with ventilation perfusion mismatch and hypoxia. So we'll discuss this in a second. Causes of cirrhosis could be alcoholic, which is called anemic cirrhosis, is the most common, but patients could develop non-alcoholic cirrhosis of the liver or fatty liver. This is basically due to obesity. It could be due to uncontrolled hypertension and also metabolic syndrome. Patients with hypertension, hypertriglyceridemia, and diabetes as well. Also, patients could develop cirrhosis of the liver due to obstruction of bile flow, due to hepatitis, due to other metabolic disorders such as Wilson's disease, galactosemia, pancreatitis, and even congenital deficiency of glycogen storage. So we talked about the major complications of cirrhosis of the liver besides hepatosplenomegaly, also portal hypertension leading to ascites, esophageal varices, GI hemorrhages, and hepatorenal and hepatopulmonary syndrome, accompanied with hepatic encephalopathy due to accumulation of ammonia. So cirrhosis may be completely asymptomatic for years. Sometimes the first symptoms are non-specific, from fatigue, anorexia, malaise, weight loss. The liver is typical, palpable and firm. There's nodules present, but they're non-palpable. Only could be seen with a CT scan or an MRI or MRCP. Clinical symptoms of chronic liver suggest portal hypertension with muscle wasting, pulmonary erythema. There is clubbing, also contractures, hair loss, and even peripheral neuropathy. Patients could have abdominal distension due to ascites, abdominal discomfort with fever, and hepatic encephalopathy due to spontaneous bacterial peritonitis. They could develop DVTs and pulmonary emboli. Patients could have clubbing and confusion due to hepatopulmonary and hepatic encephalopathy, dyspnea and hypoxia due to hepatopulmonary syndrome and pulmonary hypertension, fatigue and pallor. Patients tend to develop anemia due to GI bleed. In this case, would be normocytic pneumochromic, but also because of undernutrition, patients could develop microcytic hypochromic and macrocytic pneumochromic as well. So either iron deficiency anemia or vitamin B12 deficiency, even more in patients that are alcoholic. Patients could have oliguria and renal failure and signs and symptoms of volume overload due to hepatorenal syndrome, osteoporosis, leukopenia, and of course, high risk for infection. They could develop jaundice due to cholestasis. They could have other sources of bleeding due to thrombocytopenia and coagulopathy. Remember, the liver is in charge of vitamin K, so these patients tend to have vitamin K deficiency. Patients, due to cholestasis, they tend to have a lot of pruritus, itching of the skin, rectal bleeding, splenomegaly, as well as malabsorption. So why do patients develop ascites? Remember, these patients mainly tend to have an excess capacity of the lymphatic drainage. In addition, these patients have increased hydrostatic pressure due to portal hypertension, but mostly because patients have protein malnutrition and protein catabolism and decreased oncotic pressure. That's another reason why these patients develop ascites. So it's a combination of another way is again by increasing hydrostatic pressure there is capillary leakage and the autoregulation of renin-angiotensin aldosterone system will kick in to avoid hypovolemia. So now let's discuss again briefly what is portal hypertension. So basically it's an elevated pressure in the portal vein. It is caused most often by cirrhosis of the liver, but it could be due to any hepatic vascular abnormality. The portal vein, formed by the superior mesenteric and splenic vein, drains blood from the abdominal GI tract, spleen, and pancreas into the liver. The normal pressure is 5 to 10 millimeters of mercury with a gradient of 7 to 14 centimeters of water. That exceeds the inferior vena cava pressure by 4 to 5 millimeters of mercury, which is the normal portal vein gradient. So higher values than 15 are defined by portal hypertension. The main etiology, as I said, is due to cirrhosis of the liver, but other causes, for example, if you have a patient that has portal thrombosis, or if the patient has a parasite that affects the liver, uh, patients, for example, that have obstruction of the inferior vena cava, and as well right-sided heart failure with restrictive cardiomyopathy, and that congest the liver. Remember, right-sided heart failure tends to have not only jugular vein distension, alto mental status, but also hepatomegaly and splenomegaly, ascites. So all that will congest the liver and could produce portal hypertension. So basically, it's an increased resistance to intrahepatic blood flow, most likely produced by cirrhosis of the liver. This elevated pressure is transmitted back to vascular bed in the spleen, esophagus, and other organs, producing neovascularization and varices. That shunting that is produced from the high pressure to the lower pressure, basically what produces the decreased amount in vascular resistance and blood volume that decreases pressure in the portal system. Major complications associated with portal hypertension would be risk of infection due to a lot of translocation of bacteria at the level of the peritoneum, producing bacterial peritonitis. Patients are at risk for disseminated intravascular coagulation, splenomegaly, thrombocytopenia, as I explained, encephalopathies, viruses. Remember, the liver is in charge not only of lipid metabolism, but also protein and carbohydrates. So patients would have hyperglycemia, hypertriglyceridemia, and therefore hypoestrogenemia. That leads to changes in menstrual cycle, ovulation, as well as impotency in males. There's also bile deficiency associated with it. So if you see here, what happens is that there is liver failure that leads to portal hypertension. That increases the arterial vasodilation to be able to maintain blood volume. Patients could have alterations in sodium with hyponatremia. In addition, they could have, because of this reduction in blood volume, patients go into acute kidney injury and hepatorenal syndrome that I will explain in a second. Due to this major hypovolemia and shunting from high pressure to lower pressure system, and affecting the preload from the inferior vena cava, decreases cardiac output and therefore impairs chronotropic function. So treatment basically for portal hypertension, when possible, the underlying disorder has to be treated. Treatment of esophagogastric viruses as well that tend to bleed, as I explained before, with endoscopy banding or sclerotherapy, balloon uh, as well to prevent more bleeding. In addition, patients could have beta blockers to decrease the portal pressure, such as propanolol, timolol, carvedilol. That is also used for heart failure. In addition, patients could have portal systemic shunting, which is the TIPS procedure, and even up to liver transplantation. So now let's explain the hepatorenal syndrome. This syndrome basically consists of progressive oliguria and azotemia, meaning elevation of BUN and creatinine in the absence of any structural damage of the kidney. It usually occurs in patients with not only cirrhosis of the liver, but with fulminant hepatitis, and patients that have ascites of any cause. There is extreme vasodilation, and that's the main keyword for pathophysiology: vasodilation of the splenic arterial circulation, leading to decreased central arterial volume, as I explained here. So what happened here is that the central volume is impaired, leading to hypovolemia. If the patient have hypovolemia, remember there is a shunting from the organs that are not necessary, which is the kidney, the GI tract, diminishing glomerular filtration rate. There is low urinary sodium concentration, Patients tend to have tubular necrosis and pre-renal azotemia or pre-renal renal failure. So once renal failure is established, patients could progress to severe renal insufficiency. So basically, it's characterized by rapidly rising of BUN and creatinine that does not improve with volume expansion. The patients try to auto-regulate first by vasodilation, shunting away blood to the main organs due to central hypovolemia, but late states is characterized by severe renal vasoconstriction, low urine sodium, normal preload, which is central venous pressure. So basically, the patients would have the same signs and symptoms of an acute renal failure. The treatment could be a combination of vasoconstrictors, which is midodrine or sandostatin, or up to transplantation or TIPS procedure. In addition, patients could have nitric oxide or endothelin that regulate vasoconstriction and lead to retention of sodium and water to improve this. Another symptom that patients are at risk for when they have cirrhosis of the liver is hepatopulmonary syndrome. Again, this is hypoxemia caused by pulmonary microvascular vasodilation in patients that have portal hypertension associated with dyspnea, hypoxia. So basically, is the result from formation of microscopic intrapulmonary arteriovenous vasodilation. The mechanism is basically unknown, but it's thought to be due to increased hepatic production or decreased hepatic clearance of vasodilators. It could be also caused by over perfusion relative to ventilation, leading to a mismatch. Patients, when they have hepatopulmonary syndrome, instead of having orthopnea or paroxysmal nocturnal dyspnea, meaning that normally the patients, when they have, for example, volume overload state, such as in CHF, when the patients are laying flat, they are very short of breath, they cannot lay flat, or they wake up suddenly during the middle of the night because of dyspnea. These patients have completely the opposite. They have what is called platypnea, Platypnea, or orthodixia, which is the hypoxemia that improved when the patients are laying flat, and is worse when the patients are in standing up position. So this is basically due to a redistribution of vasodilatory substances that are released. Patients actually feel better when the volume is redistributed in recumbency position. So there is an increased ventilation perfusion mismatch with shunting of blood in the lungs, over distending the capillaries that are not fully diffused, creating a hypoxemic event. So if you see this is a normal alveoli, normally when the patients have, for example, pulmonary emboli, there is a deviation of blood flow, which is called the classic shunt. The blood basically bypasses the alveoli, whereas in hepatopulmonary syndrome, right here, there is the oxygen failure to diffuse due to massive vasodilators that are released. This is basically the main treatment for it. Now let's talk briefly about pediatric abnormalities. The majority and more common are cleft lip or palate, esophageal atresia or pyloric stenosis, intestinal malrotation, meconius ileus, Hirschsprung disease. We're going to basically discuss a few of them. So let's start with intussusception. which is no more than a telescoping of one portion of the intestine into itself, that basically invaginates into itself, causing intestinal obstruction and ischemia. Generally, this occurs between the ages of 6 months to 3 years. The majority of the cases occur before age 1, and is the most common cause of intestinal obstruction in pediatric population. The causes are mainly idiopathic. There is slight male predominance as well as season variation that coincides mostly with summer due to viral enteritis season, uh, mainly due to rotavirus. These patients are high risk for intussusception. The newer vaccines, against MMR and all that, tend to decrease the risk for intussusception. So basically, the telescoping segment obstructs the intestine and ultimately impairs blood flow, causing ischemia, gangrene, and even perforation. Uh, Patients that are also risk for this are patients that have lymphoma, patients that have cystic fibrosis. So the initial symptoms are sudden onset of colically abdominal pain that recurs every 15 to 20 minutes. So it's in cycles, that is associated with vomiting. The child during the normal episodes appears very well. Later, as intestinal ischemia develops, the pain becomes more steady. Patient could become lethargic with mucosal hemorrhage, and rectal examination. Patients tend to have current jelly stools, palpable abdominal mass also could be present due to the telescoping, and is described as a sausage shape. Perforation could occur very, very often, as well as ischemia. It's diagnosed by ultrasound. You could do viral enema as well. It was once preferred as the initial study, but you have to be very careful if the patient has any sign of ischemia or perforation. Treatment for that will be basically, if intussusception is confirmed, air enema is used for reduction. Try not to put any contrast because if the patient has perforation, that could go into the peritoneum. And if if enema is unsuccessful, then or if perforation is present, patients should go surgical procedure. Now let's talk about briefly on Hirschsprung disease. This is a congenital anomaly of innervation of the lower intestine. Basically, it's usually limited to the colon, resulting in partial or total functional obstruction. This is nothing that is obstructing, is functional. Remember, it's the parasympathetic system. So it's congenital absence of autonomic plexus or the parasympathetic system in the colon. Those are called the Meissner and Archbach autonomic plexus. The disease tends to be limited to the distal colon, even though the entire colon could be affected. Males are more common than females. There's likelihood of being hereditary, so family members having this disease in the past increases the likelihood. Peristalsis in the involved segment is absent or abnormal, resulting in continuous smooth muscle spasm and partial or complete obstruction. Uh, the children, very common in early life. 98% of neonates tend to pass meconium in the first 24 hours, but about 40% of neonates with Hirschsprung disease fail to pass meconium in the first 24 hours of life. Sometimes presenting with obstipation. Remember, it's nothing, gas or fecal matter going through it. Abdominal distension, vomiting. Occasionally, there is also intermittent constipation instead of obstipation. Patients could have mild diarrhea, but the main difference here is that when you do a digital rectal examination, the rectum is empty. So the patients tend to have colic. They could even have explosive passage of stool when you withdraw the finger, which is called the blast sign, diagnosed by Byron Emma, rectal biopsy, or even rectal manometry. And the treatment is basically surgical. So another disease that we'll discuss will be cystic fibrosis. It's basically an inherited disease of the exocrine gland affecting primarily the GI tract, but also the respiratory system is compromised. It leads to chronic lung disease, pancreatic insufficiency, hepatobiliary disease, and also abnormality of the high sweat electrolytes. Is basically an autosomal recessive trait responsible for chromosome 7 that encodes a membrane associated protein called cystic fibrosis transmembrane conductor regulator. So what happened here is that this conductance regulator is in charge of chloride channel, regulating chloride and sodium transport up across the epithelium. When there is a mutation of this, nearly all exocrine glands are affected. The secretions becomes thick, so there's obstructed and viscous or solid material in the lumen of the intestine, the pancreas. There is also tracheobronchial thick secretions accumulated, and there's also excess of sodium and chloride produced by sweat, parotid, and salivary glands. So if you look here in the respiratory, patients tend to have bronchiectasis, bronchitis, pneumonias, pneumothorax, even respiratory failure with cor pulmonale. Patients tend to have right ventricular hypertrophy due to primary pulmonary hypertension, hypersplenism, GERD, pancreatitis, insulin deficiency, and diabetes. Reproductive wise, they tend to have amenorrhea and infertility. Intestinal meconius, ileus or peritonitis, intussusception, volvulus, appendicitis, and even up to hernias. Patients have osteoporosis and osteoarthropathies. In the gallbladder, they tend to have cholelithiasis, cholecystitis, obstructive jaundice, and even biliary cirrhosis. Portal hypertension associated with it, nasal polyps and sinusitis, and even failure to drive, malabsorption syndromes, and vitamin deficiencies as well. How do you diagnose this? Basically, there's a universal newborn screening for cystic fibrosis. It's now the standard, but you could do sweat testing with basically it's a test that you stimulate the sweating by pilocarpine, and the amount of sweat is measured, and also the chloride concentration is measured as well. You could also test for the gene. You could do pancreatic test, and also of course pulmonary function test. So now let's talk briefly about necrotizing enterocolitis, which is an acquired disease primarily in preterms and sick neonates. What happens here is that in addition to prematurity, there is either prolonged rupture of the membranes with amnionitis, there's birth asphyxia, or patients could have congenital heart diseases, or even any disease process that patients have profound hypoxia and leads to mucosal and intestinal necrosis. The symptoms and signs tend to be feeding intolerance, lethargy, temperature instability, bloating, hematochezia, which is red blood passed through the rectum, and even up to sepsis and apnea. So, even though the exact etiology is unclear, it is believed that any ischemic insult, and that's the key word, damaging the intestinal lining, leads to increased intestinal permeability and susceptibility to bacterial infection. So, rarely occurs before enteral feeding, and it's even less common in infants that are breastfed. However, once feedings are begun, since there's a proliferation of bacteria, normal flora, there is high risk for contamination and sepsis. The initial ischemic insult may result from either vasospasm of the mesenteric arteries or any type of anoxic insult that drives this ischemic or low blood flow to the intestine and superimposed sepsis. Now, how would the patients present? As I said, emesis or abdominal distension or even blood through the rectum. You detect this by abdominal x-ray, and basically you stop the feeding, put nasogastric suction, fluid resuscitation, antibiotic, and put the patient on TPN. Now, lactose intolerance is a type of carbohydrate intolerance. It's the inability to digest carbohydrates due to lack of lactase in this case. Patients tend to develop abdominal distension and flatulency every time they're exposed to it. Pathophysiology, normally the carbohydrates are split by lactase, maltase, or even sucrase located in the brush border of the small bowel. These undigested carbohydrates cause an osmotic load that attracts water and electrolyte into the bowel, causing watery diarrhea and bacterial fermentation. That's the reason why the patients have flatus and distension and abdominal pain. And basically, the treatment is to avoid the carbohydrate. And for symptomatic patients, they could take, lactose free or any preparation or an enzyme supplement of, to improve the symptoms. And this is basically the end of this PowerPoint.